All right, guys, so we're back here, Barbara Garcia with Restrictive Pulmonary Disorders, Chapter 23. All right, so remember, restrictive pulmonary disorders result from some sort of decreased lung expansion. So alterations in the lung parenchyma, which is like the tissue of the actual lung, in the pleura, which is the membranes around the lung, right? The chest wall or some other neuromuscular function that decreases the ability for the lungs to expand, right? So it could be acute or chronic type of lung dysfunction. So you might have pulmonary, which is within the lung, and extrapulmonary, which are like the membranes or outside of the lung, or some sort of nervous disorder, excuse me. So you have a decrease in vital capacity, total lung capacity, functional residual capacity, and residual volume. So there are going to be decreases in all of those, right? The greater the decrease in lung volume, the greater the severity of the disease, right? So obviously, if you have decreased vital capacity, you're going to have a harder time oxygenating properly, right? Arterial blood gases, right, are going to show a decrease on partial pressure of O2, normal, perhaps, or decreased partial pressure of carbon dioxide, and increased pH, as in alkalosis. All right, so fibrotic interstitial lung disease, right? So this is a group of disorders that are going to be interstitial, so within the lung parenchyma, right? They are either acute, subacute, or chronic, and there's an infiltration of the alveolar walls by either cells, fluid, and or in connective tissue. If left untreated, may progress to irreversible fibrosis. All right, so diffuse interstitial lung disease, right, is characterized by a thickening of the alveolar interstitium. All right. So pathogenesis, this diffuse interstitial lung disease begins with some sort of injury in the alveolar epithelium, or capillary endothelial cells. Remember, the capillary endothelial cells are simple squamous, and so are the alveolar epithelial cells. They're both simple squamous. So they are very thin to allow for easy diffusion of oxygen and carbon dioxide. Right? So alveolitis can lead to obliteration of these capillary, the alveolar capillaries, and then reorganization of the lung parenchyma. And so this can basically lead to irreversible fibrosis. So also you're going to see maybe large filled air sacs, we call cysts, and then with some of the dilated terminal and respiratory bronchioles, so that we have a honeycombing of the lung. All right, so 3 pathological patterns. So you're going to have inflammatory, fibrotic, and destructive, right? So what you're going to see in this diffuse interstitial lung disease are some progressive dyspnea, right, with irritating and a non-productive cough, rapid shallow breathing, clubbing of nail beds, and then you're going to hear bibasilar and expiratory crackles. So crackles at the basilar ends of the lung. So cyanosis, also anorexia and weight loss, and then an inability to increase cardiac output with exercise. Some of the more important clinical manifestations. All right, so diagnosis is going to be through a chest x-ray. You might see pulmonary function tests that are going to have a decreased vital capacity, total lung capacity, and diffusing capacity. You might also see lung biopsies, transbronchial biopsies, or a gallium-67 scan. High resolution computed tomography and bronchial alveolar lavage are often the primary tests for this interstitial lung disease. So smoking cessation, and especially if there's some sort of environmental exposure, that's one of the most important things to eliminate, right? Administer some anti-inflammatory agents or immunosuppressive agents, and oxygen if necessary for hypoxemia, and you might even need a lung transplant. All right, sarcoidosis is the acute or chronic systemic disease of unknown cause, okay? So usually some sort of disease that we don't know of can cause sarcoidosis. Immunologic is probably the most likely cause, and so activation of alveolar macrophages to some unknown trigger. And then if there's a first degree relative with sarcoidosis, you'll see an increase in the risk. All right, pathogenesis, right? Development of multiple, uniform, non-cacheating epithelioid granulomas affecting multiple organs and abnormal T cell function. All right, the pathogenesis of sarcoidosis involves this epithelioid granulomas, right? Affecting multiple organs, non-cacheating form, and has an abnormal T cell function. All right, so some of the clinical manifestations include malaise, fatigue, weight loss, fever, dyspnea, right, of insidious onset, and a dry, non-productive cough. So what are some of the clinical manifestations is erythema nodosum, which are painful nodules in the lower extremities, right? You'll see macules, papules, hyperpigmentation, and subcutaneous nodules. You might also see hepatosplenomegaly and lymphadenopathy. Right? So diagnosis is going to be made by looking at a CBC and looking at some low white blood cell counts, leukopenia, and you might also see some low red blood cell counts for a diagnosis of anemia. You might see increased eosinophil count and an elevated sedimentation rate. An elevated sed rate is seen in diseases that are inflammatory in nature, so that the red blood cells, because they have this extra proteins because of the inflammation, it's going to, the red blood cells sink to the bottom faster. So they have a increased or elevated sedimentation rate. Increased calcium levels, elevated liver enzymes, anergy, elevated angiotensin converting enzyme in active disease. Right? You also are going to use a gallium-67 scan to localize those areas of granulomatous infiltrates, those pulmonary function tests, and then this transbronchial lung biopsy for the granulomas, so that we can take a biopsy and look at it. Remember, cacheating granulomas indicate tuberculosis, so sarcoidosis is going to be non-cacheating. You might also see bronchiolar lavage, and they are staged between 0 and 4, progressing from normal to advanced fibrosis with a greater evidence of honeycombing. Hilar retraction. Remember, the hilum is the area right against your heart, which is where all of the blood vessels and the bronchi go in and out. That's the hilum, right? So you're going to see a retraction of the hilum, the bullae, cysts, and emphysema. All right, so what are the treatments for sarcoidosis? Management of the individual symptoms, corticosteroids, immunosuppressive agents, and hydrochloroquine for some of the disfiguring skin lesions, hypercalcemia, and neurological involvement. Hypersensitivity pneumonitis, also known as extrinsic allergic alveolitis, is restrictive and usually occupational in nature, and it's a predominant in non-smokers. It's usually a genetic predisposition where your antigen combines with an antibody in the alveolar walls, leading to a type 3 hypersensitivity reaction. So remember to review some of your hypersensitivity reactions. And antigen antibody complexes then can elicit some granulomatous inflammation, leading to lung tissue injury. And so when you have diffuse pulmonary fibrosis, which is a very hallmark of the disease, is then going to lead to that restriction. And so acute, right, in the short term, right, some of the symptoms are going to start about 4 to 6 hours after exposure and resolve in about 18 to 24 hours. And they include chills, sweating, shivering, myalgias, nausea, malaise, lethargy, and headache, right? Dyspnea, dry cough, tachypnea, chest discomfort, cyanosis, right? So that linear, right, the nodular, reticular, or linear findings of the deposition of these different anthracoses or silicosis. Right, so pulmonary function tests is very similar to restrictive lung disorders, as you saw in the previous chapter, chapter 22. I had a whole chart on those, so you might want to look through those, indicating some restrictive diseases, right? And then arterial blood gases that are also going to be with a low partial pressure of oxygen You might see also hypercapnia. And then the treatment for some of these is obviously limiting the onset and severity, and then continuing adherence to federal standards for any dust and particulate matter, and then obviously continuing the education of workers and employers so that they know that they are being exposed, and if possible for them to have them wear masks or something of that nature to prevent further exposure. All right, so some treatments: corticosteroids, inhaled bronchodilators, oxygen therapy, intermittent positive pressure ventilation if necessary, postural drainage, so that they get in a certain position so they can drain the mucus, and some deep breathing exercises. Right, so pneumoconiosis, diseases of the lung, right? A, they deform the chest wall and pleura. B, are effectively treated with antibiotics. C, produce antibodies to the causative agent. D, damage alveolar walls from macrophage impairment. Answer to that is D. Right, so the atelectic disorders, right, that lead to lung collapse, the most severe is adult respiratory distress syndrome, or also referred to as acute respiratory distress syndrome. The etiology is some damage to the alveolar capillary membrane, right? So this protein-rich infiltrates are going to find their way into the alveoli and then causing severe dyspnea, and then usually associated with some other pathophysiologic processes like pneumonia. Right, so about 150,000 cases a year, and the mortality rate is quite high, with some studies finding 30 and other studies finding up to 63%. So there's a decline in the partial pressure of oxygen that is refractory, which means it does not respond to supplemental oxygen therapy. Some causes include sepsis, severe trauma, aspiration of gastric acid, fat emboli syndrome, and shock. Right, so increased permeability of the pulmonary vasculature, right, leading that with the proteinaceous fluid filling the alveoli. So it leads to a protein-rich pulmonary edema. So it's a non-cardiogenic pulmonary type of edema, which triggers the immune system to activate the complement system and then initiate neutrophil sequestration in the lung. Right, so in other words, the immune system is sort of kind of moving into the lung, and it's really causing some situations in which it's destructive to the tissue. Right, so injury to the alveoli could be from a wide variety of disorders. Right, there's changes in alveolar diameter, and injury to the pulmonary circulation, right, atelectasis, which is lung collapse, and decrease in lung compliance, right, from lack of surfactant. You might see fibrosis in the hyaline membranes, and diffuse fluffy alveolar infiltrates, and a lot of disruptions in O2 transportation. So you resulting in a severe hypoxemia. So you might see here the thickening, as you can see here, alveolar damage. So that thick wall, remember the alveoli is supposed to be simple squamous, so there's no need for this thickening of the wall. That is definitely irregular. Right, so the history of a precipitating event that leads to a low blood volume state or a shock state 1 to 2 days prior, which again could be sepsis. Right, so early sudden marked respiratory distress, slight increase in pulse rate, dyspnea, low partial pressure of oxygen, and shallow rapid breathing, and then you're going to see some tachycardia, tachypnea, hypotension, marked restlessness, some frothy secretions, crackles, bronchi on auscultation, use of accessory muscles, intercostal and sternal retractions, and cyanosis. So those are some of the late clinical manifestations of ARDS. All of those very, very serious. So the hallmark is the hypoxemia that's refractory to increased levels of supplemental oxygen. So you're giving oxygen, but you're not getting any more saturation of oxygen, right? So an ABG is still telling us that there is hypoxia, There is acidosis, so your pH is down and you're still hypercapnic, which means you still have lots of carbon dioxide in the blood, right? So the chest x-ray may start out as normal and will progress to a diffuse whiteout. So remember that the infiltrates will appear white in a chest x-ray. So you'll have a whiteout because all of the infiltrates will be throughout the lungs. Right? So you can see here that whiteout for the infiltrates that you'll see in the lung. Right? So some pulmonary function tests will have a decrease in your force. Excuse me, that's actually a functional residual capacity. So there's a decrease in FRC. So that's a little typo there. So that's FRC, right? Decreased lung volumes, decreased lung compliance, and a ventilation perfusion mismatch with a right to left shunt. Open lung biopsies are showing you atelectasis, hyaline membranes, cellular debris, and interstitial and alveolar edema. So the treatment is usually supportive and somehow enhancing tissue oxygenation until the inflammation resolves, identifying the threat if that's possible and the underlying cause, maintaining fluid and electrolyte balance. Right, and so but too much fluid administration can produce or even intensify the pulmonary edema. So that's maintaining the right balance. Right, so ventilator is usually used to support, right, mechanical ventilation with a positive end expiratory pressure, what we call PEEP, P-E-E-P, right, increases that forced respiratory capacity, functional residual capacity, and prevents alveolar collapse at end expiration, right? So that also forces the edema out of the alveoli. Right, so supplemental O2 can contribute to ARDS related to the absorption atelectasis. So FiO2 is reduced as soon as possible. So you might see high frequency jet ventilation or inverse ratio ventilation or inhaled nitric oxide as some other treatments for ARDS. Now, infant respiratory distress syndrome, that's why that one was adult. This one was more found in children. Right, is quite similar to ARDS, but is a syndrome of premature neonates, right? So they usually also called hyaline membrane disease, right? So in 60% of infants born less than 30 weeks that are not treated with corticosteroids, and even 35% for infants receiving antenatal steroids, and very, very low incidence in children over 34 weeks gestation, born at 34 weeks gestation, right? So these are for children who are basically haven't made surfactant, okay? Characteristics, right? Hemorrhagic pulmonary edema, patchy atelectasis, and hyaline, or what we call glassy membranes, right? And then you will see hypoxemia, right? That is refractory to increasing levels of oxygen supplementation. So high risk factors, being born prior to 25 weeks gestation, birth with an advanced gestational age, poorly controlled diabetes in the mother, deliveries after antepartum hemorrhage, cesarean section without antecedent labor, perinatal asphyxia, a second twin, a previous infant with RDS, and RH factor incompatibility. So all of those can result in IRDS, right? So primary cause is the lack of surfactant. So the child that is born without sufficient surfactant has to basically reinflate their lungs pretty much every single time that they're breathing to open the alveoli and produce sufficient pressure to drive oxygenation, right? So that you will see the patient, the baby, struggling so much to breathe that often the death, if it is caused from IRDS, is due to the baby not being able to reinflate their lungs. So they die really of energy failure, right? Because they don't have enough energy for that. They're not eating enough for that. right? So soft compliant chest that is usually drawn inward with each inspiratory contraction of the diaphragm as they're struggling to breathe. And so you'll see that in babies. So you look like when you see a premature baby being born, you will see that inward draw, a contraction of the diaphragm, right? Leading to increased alveolar surface tension and decreased lung compliance, right? So increased work of breathing and then a decreased ventilation. Then you also will have exudates into the alveoli. And so forming those very glassy hyaline membranes, and then eventually progressing into damage to the basement membrane and respiratory epithelial cells, and could lead to death. All right, so secondary cause is immaturity of the capillary blood supply, right? So that leads to a ventilation perfusion mismatch, right, with metabolic acidosis and hypoxemia. So you might see the right to left shunt also be from an open foramen ovale or a patent ductus arteriosus. So remember, you're going to have a right to left from the right side of the heart to the left side of the heart shunt. That may increase the hypoxemia because you're having the deoxygenated blood mixing with the oxygenated blood. So that's what we mean with right to left shunt. To left to right shunt isn't as bad because remember, that just means that you are pushing oxygenated blood into deoxygenated blood area. All right, so some of the clinical manifestations: shallow respirations, right, intercostal, subcostal, or sternal retractions, flaring of nares, your hypotension and bradycardia, peripheral edema, low body temperature, oliguria, and tachypnea. Right, so some the later manifestations: frothy sputum, central cyanosis, expiratory grunting sounds, and paradoxical respirations. So you'll see that seesaw movement of the chest wall. Right, so hypoxemia and metabolic acidosis on your arterial blood gas, and hypercapnia with respiratory acidosis as the disease progresses. So you'll see the chest x-ray with whiteout or ground glass, which is indicative of bilateral atelectasis and alveolar edema. So you might also see hypoinflation, which means low inflation of the lung. All right, so lecithin sphingomyelin ratio is also low in the amniotic fluid. So, and a desaturated phosphatidylcholine concentration, that is to determine the ability of the fetus to secrete surfactant. So if it's greater than or equal to a 2-to-1 ratio, the incidence of RDS in children is very low, right? So because the presence of phosphatidylglycerol indicates pulmonary maturity. So we want to see that LS ratio, right, higher, so that we can have a higher level of maturity of the lungs, right? So LS ratio, the lecithin sphingomyelin ratio, can increase with the administration of glucocorticoids before delivery. So if the baby is going to be delivered early, usually glucocorticoids like cortisol or corticosterone are going to be administered. All right, so treatment, prevention is the primary goal, and if not, corticosteroids prenatally or antenatally. Maintaining oxygen levels, right? So we also want to keep the FiO ratios low because that could also lead to further alveolar damage and pulmonary hypertension, and even retrolental fibroplasia, excuse me, which can lead to blindness. Mechanical ventilation with PEEP or continuous positive airway pressure may be necessary. Exogenous surfactant administration, usually either bovine, porcine, or synthetic, that is a really, really important to decrease mortality in these children, right? And so high frequency ventilation, right? So you can, provides obviously a uniform lung inflation, also improves lung mechanics and improves gas exchange. So these children will probably be in neonatal ICU with a whole lot of things being administered so they can breathe properly. So treatments, antibiotics, if there's an infection after the culture, their inadequate intravenous nutrition, fluid and electrolyte balance, minimal handling, and a neutral thermal environment. So a nurse is teaching the staff about adult respiratory distress syndrome and infant respiratory distress syndrome. Which information should the nurse include? In both ARDS and IRDS, the cause is a lack of surfactant. The pulmonary compliance is decreased. Hypoxia responds to oxygen therapy. Large volumes of parenteral fluids are useful. All right, so these are both restrictive pulmonary disorders, so pulmonary compliance is decreased. Because the lack of surfactant is only with the IRDS. All right, so pneumothorax, right? So pneumothorax is when there's accumulation of air in the pleural space. So how do you get a pneumothorax, right? It could be spontaneous. It's called a primary pneumothorax. Occurs in tall, thin men, 20 to 40 years of age, with no underlying disease factors, although cigarette smoking does increase the risk. So then a secondary pneumothorax is as a result of some sort of complication with other pulmonary diseases, right? A catamenial pneumothorax associated with menstruation, primarily in right hemothorax, associated with endometriosis. And a tension pneumothorax is usually traumatic in origin from a penetrating or non-penetrating injury. Could be also iatrogenic, remember, which means out of some sort of medical treatment. And it's a medical emergency. All right, so this tension pneumothorax can be caused by a gunshot wound or a knife wound. All right, so primary, right, the rupture of small subpleural blebs in the apices, the apexes of your lungs, right? And so air enters the pleural space, lung collapses, and the rib cage springs outward, right? And in secondary usually is result from some other underlying lung problem, so may be due to a rupture of a cyst or bleb. So tension, you'll see results in buildup of air underneath the under pressure in the pleural space. Air enters the pleural space during inspiration but cannot escape during expiration. And so the lung on the same side collapses and forces the mediastinum towards the contralateral side. So you'll see the mediastinum being deviated in X-ray, right? So decreases venous return and cardiac output. So you can see that deviation, right? Right, so open sucking the chest wall type of wound where the air enters during inspiration but cannot escape during expiration, then leads to a shift of the mediastinum. Right, so most clinical manifestations, right, are not detectable on physical exam because they're very small, right? You might see tachycardia, absent or decreased breath sounds on one side, hyperresonance, sudden chest pain on the affected side, and dyspnea, right? So the large and tension spontaneous pneumothoraxes are much more emergency situations and can have a severe tachycardia, hypotension, and tracheal shift, right? Neck vein distension, hyperresonance, and subcutaneous emphysema. So you could see a subcutaneous emphysema in this patient, right? Makes it very, very difficult to breathe. Right, the ABG decrease partial pressure of oxygen and acute respiratory alkalosis. And in EKG, also you might see some changes with non-specific ST changes and axial deviations in the EKG, and the chest X-ray, right, show a better demarcation of the pleural line than in inspiratory, and the depression of the diaphragm side, right, of the hemidiaphragm on the side of the pneumothorax. So you'll see kind of almost like a balloon-like lung, right? So management depends on the severity of the problem and the cause of the air leak. So the lung collapse is very common, right? Patient may or may not be hospitalized. Treat symptomatically, and then the lung collapse in greater than 15 to 25% of the time requires a chest tube placement with an water seal and suction, and usually oxygen, supplemental oxygen. Right, so you might see adhesion of the visceral pleura to the parietal pleura to prevent further ruptures, especially for recurrent spontaneous pneumothoraxes. And thoracotomy, right, like a type of stapling or lasering of the ruptured blebs. Right, so the etiology of a pleural effusion. So what is a pleural effusion? A collection of fluid or pus in the pleural cavity as a result of some sort of disease process. So normally about 5 to 15 mL of serous fluid is contained in the pleural space, right? And so that constant movement of fluid is normal, right, from the parietal pleural capillaries to the pleural space, and is reabsorbed into the lymphatics. And so pleural effusion is an increase in that. So 5 major types: those that are transudates, were very low in protein, right? So this is associated with severe heart failure or other types of edema. Exudates, which are high in protein, causing malignancies, right? Infections, caused by malignancies, infections, pulmonary embolism, sarcoidosis, post-myocardial infarction syndrome, and pancreatic disease. You might see epema, right, due to infections. So an exudate, a high protein exudative effusion. A hemothorax, which is blood, right, usually resulting from some sort of chest trauma, may contain, right, blood and pleural fluid, so some sort of hemorrhagic origin. Or chylothorax or lymphatic, which are exudates from the lymphatic fluid that can also find its way into the pleura. Right, so basically the pleural capillary, right, hydrostatic pressure, colloid oncotic pressure, or intrapleural pressure have somehow been changed, and this imbalance in pressure is going to cause fluid formation, and the fluid removal is not going to be fast enough to keep up with the fluid formation. Right, so transudates, remember, low in protein, right, increased hydrostatic or decreased oncotic pressure, right? So remember, oncotic pressure has to do with the movement of fluid from the tissue back into the blood, because the blood is high in protein and the tissue fluid is low, right, in protein, right? So exudates, right, increased permeability of pleural membrane or impaired lymphatic drainage. So you might see clinical manifestations varying depending on the size of the effusion, right? You might see dyspnea, right, decreased chest wall movement, pleuritic pain, right? So in trying to breathe, right, on inspiration you get a sharp pain and dry cough, and so very asymptomatic in people with very little fluid in their pleural cavity. So if their pleural effusion is not great enough. You might see absence of breath sounds or dullness in percussion, which is one of the primary findings. Tactile phremesis is a vibration that indicates the accumulation of fluid, or what we call consolidation in the lungs. So if they say certain words, upon palpating the back of the lungs, you're going to feel a vibration. Contralateral tracheal shift if there's a massive effusion. Right, so chest x-rays are going to show you those densities or infiltrates in the pleura, right? Signs of congestive heart failure, right? Hilar adenopathy and the location of fluid. So you might need to do a thoracocentesis, right? So that's going to involve a reduction and then analysis of the fluid. And then the CT or ultrasonic tests can also be used to aid in complicated effusions. So you might distinguish, for example, a mass from a large effusion if that wasn't distinguishable before. All right, then a treatment. What is the underlying cause? So relieving the underlying cause and the symptoms are going to be the primary treatment of pleural effusion. right? If it's tension or spontaneous pneumothorax, which are emergencies, we have to remove the pleural air and re-expand the lung. So you might also see closed chest tube drainage in adults, and quite controversial in pediatric population. The thoracocentesis, if a large amount of effusion, right? So an ultrasound could act as a guide, and a thoracotomy to control bleeding if necessary. Poliomyelitis is one of our first neuromuscular disorders that we're going to discuss, right? The polio is a viral disease, right? Where you're going to have attack of the motor cells of the spinal cord and brainstem. Very few cases per year in the United States, and the new cases are rare but are related to vaccination. Okay, so usually occurs in unvaccinated immigrants, and it's about 95% in infections are asymptomatic.